The Walk in Our Shoes report was commissioned by the National Stroke Foundation in 2006 to assess the attitudes, knowledge, behaviour and needs of stroke survivors and their carers. The NSF used interviews and surveys to find out how stroke had impacted on their lives, what post-stroke support they needed, and in particular, what would make a difference. In 2008, the NSF employed consultants to develop a national stroke strategy that recommended the establishment of stroke liaison officers to help stroke survivors and their carers to transition from the hospital system to the community care system. However, from the point of view of stroke survivors and carers living in Australian communities, we have seen negligible improvement in the availability of community support to stroke survivors and their carers, many of whom are still wallowing in our individual black holes. In the words of that venerable physics educator, Professor Sumner Miller, why is it so? Let's start with a brief overview of the current system in which we stroke survivors and carers find ourselves. This system can be seen as having two parts, a hospital care system and a community care system in which the major stroke stakeholders operate. The yellow circles show some of the major medical and hospital stakeholders, and the red arrows show the interactions of stroke survivors and carers with those stakeholders. The blue squares show the stroke organisations operating at the national, state and local levels, and the blue arrows show the interactions between those organisations, stroke survivors and major medical and hospital stakeholders. Another way of looking at the current system is to see it as a continuing care pathway or journey for stroke survivors and their carers, with three distinct stages. The acute care stage commences immediately after the stroke occurs. It includes the ambulance trip to the emergency ward of a local hospital, the diagnosis of the cause of the stroke, the administration of TPA drugs if appropriate, and the stabilisation of the medical condition of the stroke survivor. The subacute stage commences when the stroke survivor is transferred to a stroke rehabilitation facility where, hopefully, intensive physiotherapy, occupational therapy and speech therapy occurs with the aim of recovering enough functionality for the stroke survivor to be discharged into appropriate community care. The community care stage commences when the survivor is discharged from their rehabilitation facility to live in their own home or in appropriate supported accommodation. It is then that the responsibility for ongoing care is transferred from the hospital system to the community care system. And this is where the current system starts to fail us. So, who is us? We are part of the 350,000 stroke survivors living in Australian communities with their carers and family members, not to mention the 35,000 additional stroke survivors discharged into Australian communities each year. So let's look at why the major stakeholders in the stroke industry are continually failing us. First, let's look at the acute and subacute hospitals in Australia, which are responsible for the acute care and subacute care stages of this continuing care pathway for stroke. Despite the enormous pressure on public hospitals to handle an increasing number of strokes in an ageing population, the hospitals generally provide amazing services to people who suffer strokes, and they are getting better and better at saving lives and restoring basic functionality to stroke survivors. But the focus of the hospitals must be on the acute and subacute stages of the stroke recovery journey. They cannot be expected to support stroke survivors and carers indefinitely, and must discharge stroke survivors to the community care system and to their eventual fate of having to navigate the highly fragmented system for the services they need. Hospitals simply do not have the financial or skilled human resources to provide long-term community care. They can only ever be effective players in the acute and subacute stages of our stroke recovery journeys. And for that, we must always recognise the debt we owe them. We now come to the community care stage of the continuing care pathway for stroke, where we switch from a relatively short-term reliance on acute and subacute services to a very long-term, in fact a lifelong, reliance on community-based chronic care services. In the current system, the community care stage relies very heavily on the clinic-based general practitioners. This clinic focus, as opposed to a whole of community focus, is the first of many structural problems we face, because different stroke survivors in metropolitan, regional and rural communities will receive different standards of primary health care depending on the stroke-related knowledge, skill and experience of the practitioners in their local medical clinics. Although many GPs are excellent and caring health professionals, most have not been trained in more than basic neuroscience. They do not have stroke-specific diagnostic tools. They do not have sufficient Medicare-funded time to develop and manage effective care plans for all but the most disabled stroke survivors. They often do not understand the way stroke-related disabilities interact with the moods and family relationships of survivors and carers, and how that plays back on their rate of functional recovery long after they've been discharged back into their communities. Few have the time or incentive to keep up to date with the latest research in neuroscience, and in particular, how to use the mechanism of brain plasticity to achieve meaningful recovery goals. While good GPs will refer strokies to appropriate health professionals, if there are any that their patients can easily access or afford, and then follow up on their recommendations. But some GPs consider stroke as an old people's condition and do not take the community care of their stroke survivor and carer patients seriously. From the point of view of stroke survivors and carers, it is essential that their primary healthcare professionals have the knowledge, experience, time and commitment to take care of people with complex and continually interacting physical, mental, psychological, mobility, social and communication disabilities. And these professionals must be available in all Australian communities, not just in metropolitan areas. Sadly, for many stroke survivors and carers, the role of their GP is limited to preventing further strokes by prescribing blood pressure, cholesterol and blood thinning drugs as appropriate. The next major stakeholder is the National Stroke Foundation, which is the national body responsible for stroke in Australia. Over the past few years, the NSF has been doing an excellent job in the areas of acute and subacute care, with the development of updated clinical standards and guidelines and promoting the development of stroke units in key hospitals in Australia. The NSF has also played a key role in the community care area by promoting stroke awareness and stroke prevention messages within Australian communities. But from the point of view of people who are trying to recover from their strokes, these messages are much less important than getting access to appropriate community-based support in their local communities. What stroke survivors and carers need is access to long-term chronic care in their own communities. But the issue of continuing community care is extremely difficult for the NSF to tackle, partly because of the way it is funded and the way staff are often employed on short-term project-oriented contracts. In an effort to address this issue, the National Stroke Foundation has established a web-based forum called Stroke Connect, where survivors and carers can share their own experiences, offer emotional and practical support, give understanding, answer questions, share tips on what might help, and share knowledge of services and information available. And there is a 1-800 telephone service called Stroke Line, where stroke survivors and carers can talk to a health professional and get free information and advice. No doubt these services are valuable for those who use them, but they can only ever be a partial solution to what is a dysfunctional community care system from the point of view of most stroke survivors and carers. As a result, the NSF cannot be expected to provide long-term chronic care at the community level. Instead, the NSF should focus its limited resources on continual improvement in the acute care and subacute care sectors, and in the promotion of the stroke prevention and awareness messages. And it should delegate the responsibility for long-term community care of stroke survivors and their carers to organisations which have much better links into the Australian communities where stroke survivors and their carers live. Then there are state-based stroke associations in most Australian states. But these organisations face even more severe problems with the way they are funded and the way they rely on volunteers rather than full-time staff who have credibility within the medical professions or in hospitals. This means they are unable to get access to information about stroke survivors when they are discharged from hospital. This information is absolutely essential for an organisation that wishes to take responsibility for managing the community care stage of individual stroke survivors and carers. So neither the NSF or the state stroke associations can provide effective long-term chronic care at the community level, no matter how much they want to or how hard they try. Ideally, the state stroke associations should focus their limited resources on supporting the operation of community-based stroke support groups, setting up new stroke support groups, the training of stroke support group leaders, and promoting information exchange and contacts between support group members. And the state stroke associations should receive all possible support from the NSF in building statewide and national networks of community-based stroke support groups. We now turn our attention to stroke support groups. Stroke support groups face even more severe problems than the NSF or state stroke associations in getting access to reliable sources of funds. And they have to rely almost exclusively on dedicated members who are either stroke survivors themselves or their carers. So the issues of financial and human resources and continuity are a constant threat to the survival of these groups. Furthermore, most stroke support groups lack the staff and leaders who have any credibility with medical professionals and hospitals, and this severely limits their capacity to assume a more active role in providing continuing community care. Hence, stroke support groups are unable to get access to information about stroke survivors living in their neighbourhood once they are discharged from hospital. So stroke survivors and their carers often do not know about the existence of a stroke support group in their town or suburb. So these groups find it very difficult to do anything for anyone other than their members, and these represent just a small percentage of the stroke survivors and carers living in their community. Instead, they must focus on supporting the community care needs of their members by providing stroke-related information and encouragement to their members, by improving the quality of life of their members, and helping them to rebuild their personal, family, social and community involvements. Sadly, for the majority of stroke survivors and carers in a community, stroke support groups are ineffective because they don't know they exist or what help they can provide. Finally, we have ourselves, our fellow stroke survivors and carers. But how do we continue to fail ourselves? Most of us engage in a lifelong post-stroke search for information about stroke recovery and the services that might help us to get on with our post-stroke lives. Often, that information is available on the internet, but many stroke survivors and carers do not feel comfortable using computers to gain access to that information. Instead, we tend to rely far too much on medical professionals to tell us how we should live our post-stroke lives. And although those medical professionals are undoubtedly experts on medical matters, most have no idea about how a stroke affects the interplay of temporary or permanent physical disabilities and the emotional problems they cause. Only stroke survivors and their carers can experience the effects of this complex and continually evolving interaction and the impacts they have on their quality of life. Only we know what priorities need to be placed on our post-stroke recovery to maximise our quality of life. But most stroke survivors and carers feel utterly powerless in moulding the current system to address our particular long-term community care needs. And there is no organisation that will advocate for us to change the current system from one that is dominated by issues related to acute care and subacute care to one that focuses on continuing community care. So, if the current community care system consistently fails us, what can be done to change that situation? One way is to identify an ally in the community health system which has common interests with stroke survivors and carers, and to convince them to play a major role in the stroke community care system. So, what are the characteristics of such a potential ally? A potential ally must have access to multiple reliable sources of funds, including federal, state and local governments, as well as philanthropic and charitable bodies. It must have access to stroke-related knowledge and skills, particularly in areas of allied health and social work. It must have credibility within the medical profession, so that hospitals feel comfortable in passing on the details of stroke survivors discharged into their communities. It must have a proven track record of providing a wide range of community health services. It must have a commitment, and preferably an incentive, to keep people out of the hospital system. And it must have a commitment to improving the quality of life of members of the communities they serve. There are a number of potential allies, including the newly established Medicare locals, the community health centres throughout Victoria, and the equivalent organisations in other states. But let us focus on one of these possibilities for a moment, and that is the community health centres. There are 100 community health centres currently operating within Victorian communities. They offer a wide range of primary health and community services, such as allied health, chronic disease management, support for self-management, disability services, health promotion, exercise physiology, mental health services, and social services. Their staff typically includes general practitioners, allied health professionals, social workers, nurses, and business managers. They have reliable access to multiple sources of funds within local, state, and federal governments. And they exist, as stated in the Department of Health website, to intervene early to maximise health and well-being outcomes and to prevent or slow the progression of ill health. In other words, they exist to keep people like stroke survivors out of hospital and to improve their quality of life. So, there is a very real basis for developing a strong, long-term relationship between stroke survivors and their carers and community healthcare organisations like a community health centre. That relationship should be based on a common interest or need to keep stroke survivors and their carers out of hospital, to improve the quality of life of stroke survivors and their carers, to promote the practice of self-management by stroke survivors and carers, and to get stroke survivors and carers connected to appropriate community and health services, including connecting stroke survivors and carers to their local peer support groups or to community service organisations such as day centres. And the National Stroke Foundation could play a key role in the development of these relationships to ensure that these community healthcare organisations have access to up-to-date stroke rehabilitation information. So, what do we mean when we talk about our quality of life? In the medical context, the term quality of life refers to an individual's total well-being, including all emotional, social, and physical aspects of the individual's life. The very least any stroke survivor can hope for is to regain an acceptable post-stroke quality of life. As this diagram illustrates, a person's quality of life may drop catastrophically immediately following a big stroke as physical, emotional, mental and communication capabilities rapidly decline. Then, as the acute and subacute professionals get to work, some of that functionality recovers and the stroke survivor's quality of life slowly returns until the survivor is discharged back into his or her community. But what happens next not only depends on the fighting spirit of the survivor, but on the level of community support the survivor gets in the months and years that follow. Let's consider two possibilities here. In the first case, the survivor has poor community support. That is, limited access to community services to rebuild his or her post-stroke life. What we might expect to happen here is that there is an initial increase in quality of life as the stroke survivor continues to regain functionality. But things eventually become just too hard, and the stroke survivor sinks down into their own big black hole and a lower quality of life. On the other hand, if the survivor has good community support, we might expect a continuing increase in quality of life as the survivor discovers new activities that make use of recovered functionality and provide pleasure and meaning for the remainder of their post-stroke lives. So, in what form should that partnership between the stroke survivor community and a community health centre take? Well, one possibility is for community health centres to create special stroke consumer consultant positions which are filled by stroke survivors and or carers and which play a non-clinical role within the community health centre with non-clinical responsibility for all stroke survivors in the community served by that community health centre. The stroke consumer consultant would have close relationships with the various clinics operating within the community health centre, including GP clinics that include GPs who have special training in recent developments in neuroscience related to the promotion of neuroplastic changes that can help in stroke recovery, as well as allied health professionals, nurses and social workers. Stroke consumer consultants would work closely with one another to promote major improvements in the availability of community services for stroke survivors and their carers. The community health centre would also offer Medicare funding of services that are critical to the long-term stroke recovery process, including neurophysiotherapists and neuropsychologists, who can advise the stroke consumer consultant in the planning and monitoring of the long-term improvement in the stroke survivor's quality of life. Now let's look in a bit more detail at this stroke consumer consultant position. The first thing to understand that this is a non-clinical role, and the person who fills it will need to be trained in the operation of medical clinics so as to be able to work cooperatively with medical professionals and have basic education in the neuroscience of stroke so that they are well aware of the way a stroke might affect all aspects of a survivor's life. The responsibility of the stroke consumer consultant to stroke survivors and carers should be to provide the long-term monitoring of disabilities that impact on the survivor's quality of life. The linkage of stroke survivors and carers to community and health services that improve that quality of life. The provision of stroke-related information and education to stroke survivors and their carers, and the linkage of stroke survivors and carers to their local stroke support groups.